and Dr. Rutul Patel, PAM, a stitch in time saves lives.
Good afternoon, everyone. Yeah, my topic for presentation is PAM, a stitch in time saves 9. Basically, I have chosen this topic just to emphasize more on preventive medicine. Nowadays, we are seeing many young persons facing cardiovascular events early in age or stroke or something like that. And there are few ways where we can, as a retina surgeon, can help detect these problems earlier. So the eyes are windows to the soul. These are the few findings in the eye which can predict the systemic problems earlier and can prevent them for future complications. So coming to the paracentral acute middle layer maculopathy, that is PAM, it is an OCT-based red flag for deep retinal ischemia. I'll start with a single first case. That is a 39-year male patient, had a dimness of vision in right eye since 1 month, and vision was 6/12 in right eye. Fundus was okay. There was mild grayish discoloration just nasal to the fovea. There was a patch of grayish patch. And in OCT, grossly it was normal, but if we see the hyperreflective band towards the nasal side, suggestion of the PAM. And then we advise some systemic investigations, a coagulation profile to be specific, and there were high triglyceride as well as VLDL found, and homocysteine was also very high, more than 50. So basically, what is PAM? So it's a multimodal imaging finding, which is basically acute hyperreflective band at the level of INL. And it was originally described as an subtype of AMN in 2013, and now it is recognized as a distinct entity, which is more, which happens in intermediate as well as deep capillary plexus. So coming to the pathophysiology of the same, as we know, ICP and DCP, they are watershed zones, because of that there is a lower oxygen tension, particularly in the deep capillary plexus, which is more prone to development of ischemia. So in the initial phase or acute phase of ischemia, there is an intracellular edema, which results in the hyperreflective band in the OCT at the level of INL. And if it is not resolved in chronic phase, it can lead to the INL volume atrophy and thinning of the middle layer of the retina. In symptoms, sometimes patients may face some kind of scotoma, a positive scotoma, as well as visual acuity can be preserved in majority of the cases. So it is very difficult to diagnose in early stages without any OCT findings. Fundus may appear normal or subtle, and it may have some grayish white lesions, which is little less evident compared to the cottonwood spots. On OCT is the main key factor. In early stage, we can see the hyperreflective band in the inner layers, and in late stage, there is an INL atrophy. Opta shows some flow voids or dropout areas, specifically in the deep capillary plexus. The main differential is the acute macular neuroretinopathy, which happens in the outer retinal involvement and thinning of the ONL. Why it is important? Because it is associated with the systemic thromboembolic events, and normally it has connections with hypertension, carotid artery stenosis, sickle cell disease, or using of vasoconstrictors, as well as post-surgical hypertension. There are few articles which show direct connection in patients with isolated PAM having more chances of cardiovascular disease, stroke, and death. And here is also a case presentation showing ischemic cardiomyopathy, which was detected by PAM. Here a case where there was before CRAO, 15 days before the CRAO, the early change was seen as a PAM. So the management is the workup to find out the reason behind it and to control it. So this is also a case of 26-year male, which was just a normal routine preoperative LASIK evaluation, and we can see some areas of hyperreflectivity seen in the nasal side of the fovea. Also, that was lipid profile was altered. Similar cases in diabetic patients also. Yeah, this is a case where the untreated or the uncontrolled diabetes led to the INL atrophy in the later stage of the disease. So the take-home message is basically normal fundus is not a normal retina nowadays. We'll have to think out of the box when there is a complaint of scotoma, and patient has a scotoma. Even with 20/20 vision, we have to do an OCT and carefully see the OCT, because the PAM has some life-saving potential of detecting in early stage of any cardiac or carotid disease or the occult hypertension. Thank you.
Yeah, thank you, Dr. Rutul. It's a nice case. Nice cases regarding PAM. Anything about follow-up in these cases? Like, did you follow
Yes, sir.
these
Basically,
cases?
it's very much reversible if the underlying systemic conditions are controlled timely. The vision and the scotoma, both of them are reversible. But if the underlying condition is not controlled, like in this case is diabetic patients or hyperlipidemia, then it leads to the atrophy of the INL, and particularly scotoma may persist for a longer time or vision may deteriorate further.
Most of these patients would be asymptomatic, right?
Yes, sir.
And it's an accidental finding, or
Yeah, sir. In fundus, we may see a small grayish change if we look carefully. And otherwise, some patients, some conscious patients may present with some scotoma. They have complaints of little bit of scotoma. And particularly in OCT, if we see very carefully, we can find out this thing, Pam.
These findings are pretty common in CRAO cases, right?
Yes, sir.
So probably patients with transient visual obscuration, we can do on OCT and find such spot so that we can send for cardiac.
Yes, this is what I showed. One case where it was 15 days before the event of CRAO, they could see PAM in the OCT changes. Yeah, there was a flow void particular in deep capillary plexus area. It reverses, yes. Early stages, acute stages is reversible, chronic stage is not. Yeah. So nowadays we are seeing in more young patients also.
Have you seen regression follow-ups of these? Any of these patients have seen that OCT has become normal?
Yes, sir. Yes, sir. Actually, I couldn't bring it here, but we have seen patients with even symptomatic improvement also. In scotoma also, patient is getting better.
Without any treatment, just
Yes.
in say,
so basic thing is once you diagnose this thing,
Yeah.
you have to do cardiovascular evaluation.
Yes, the coagulation profile, 2D echo is also advisable.
Yes, thank you, Dr. Rutul. Now we move on to the next case.